Donc, nous allons maintenant donner la communication au professeur Okanakan. Good morning. Nice to see you. You have
nice to see you.
But you have just 20 minutes. I'm sorry, but the president's that. Okay, you can talk now. Thank you.
Yeah, okay. May I share the screen, please?
Yes. Yes.
Is it okay?
Is it okay? Can you? Yes, it's okay.
Yes. First of all, I would like to give my thanks for the kind invitation by Professor Mansion. I also want to thank to my dear colleagues, friends, Dominic and Karima. I would like to talk on percutaneous treatment of liver-hided cyst, cystic echinococcosis, indications, technique, results for different types, complication, and management of the complications. We have 4 options for the treatment of liver CE: surgery, medical treatment, percutaneous treatment, and wait and watch approach. Medical treatment, the results of medical treatment as indicated are still controversial. The rate of the effectiveness is very low. With mebendazole, almost half of the patients suffer from the disease after the medical treatment. Now, medical treatment is used for prophylaxis against spillage before or after surgery, as well as percutaneous treatment. And from the result of our prospective randomized studies, we understand that albendazole is needed for the prophylaxis before percutaneous treatment. What are the indications for percutaneous treatment? Viability is the most important concept for the indication of treatment. It means that according to WHO classification, CE1, 2, 3, and 3B. CE4 and 5 do not need to be further treatment. They are managed by wait and watch approach. In my opinion, surgery is only indicated if there is a kind of leakage into the biliary system, or especially peritoneum or pleural space. Like every interventional radiological procedure, as a first step before the procedure, we make a kind of imaging workup after preparation of the patient for the treatment, fasting overnight, IV sedation. We closely monitor the patient during the intervention for possible risk of anaphylaxis by the help of anesthesiology team. We carry out the procedure under ultrasonography and fluoroscopy guidance in combination. In the literature, there are mainly 3 techniques. The first one is P.A.I.R technique. The other one, second standard catheterization technique. And the third one, modified catheterization technique, briefly MOCAT. First technique means puncture of the cyst, aspiration of the cystic content, injection of hypertonic saline or alcohol, ethanol, waiting for 5 to 10 minutes, and re-aspiration. This is the most simple technique that we use for the treatment. Under ultrasonographic guidance, we nicely carried out the first puncture by traversing the normal liver tissue in order to reduce the risk of spillage. We aspirate the content. As you see, when you reduce the tension inside of the cavity, endocysts detach from pericyst. And we inject sculocidal agent, wait for 10 minutes, and re-aspirate everything. This is the simple technique. CE1, 1 year after the treatment, the second year, and 10 years later. This is defined to be a pseudotumor appearance, which means that do not enhance after contrast administration on CE, CT, or dynamic MRI. 5-year-old child came to us with 20 liver cysts in 1991. Every cyst was treated by P.A.I.R technique. 1 year later and 25 years later, all the treated cysts were partially or completely calcified, and there was no sign of viability on ultrasonography. And in time, after treatment, as seen in this case, in time, it gets solidified. Solidification is one of the major signs of a treated cyst. The second technique, in fact, is a kind of modification of P.A.I.R. After P.A.I. steps, we insert a small caliber catheter within the cavity by using interventional radiologic techniques, and we irrigate all the cavity by using hypertonic saline. Fixing the catheter into the skin, we leave the catheter to the gravity drainage. If there is no daily drainage or less than 10 cc, we carried out sclerosing agent. Otherwise, if there is a kind of communication between the cavity and the biliary system, we just keep the catheter inside of the cavity until the daily drainage stops. Otherwise, if it does not, it's possible to enter to the main bile duct by stents or nasobiliary intervention. CE1 after catheterization, and 3 months later, 2 years later, as you see, it's a small remnant. And from 1991 to 2015, there is no sign of viability. Why P.A.I.R is ineffective for CE2 and CE3A, which means that Garby type 3, the cyst, the main cyst, mother cyst containing daughter vesicles. The answer is simple. The recurrence rate is high, up to 60% of the patients, and different papers. And several authors tried to develop different modified techniques from the beginning of 90s until we developed the moquette technique at the beginning of 2000. We carried out the first puncture under ultrasonographic guidance, and then under fluoroscopy guidance, we insert 14 French catheter into the main cavity. We developed a kind of irrigation technique, which is called as effective and aggressive irrigation by using isotonic saline, not hypertonic saline. After the daily drainage by gravity drainage, we keep irrigation of the cavity a couple of sessions until the total evacuation of the cavity. As seen, one CE3B lesion, catheterization, and after irrigation. This is one video case. Under ultrasonographic guidance, the first puncture was directed. We immediately passed the guidance of fluoroscopy. We advanced a guide wire into the cavity before catheterization, as well as to destroy all the viable daughter vesicles. And then we turn the catheter in order to destroy all the viable daughter vesicles, and we irrigate the content in order to evacuate everything, not only the fluid component, but also the degenerated part of the cavity. Under ultrasonography, it looks like a balloon. When you inject water in it, it gets larger. When you aspirate it, it gets smaller. This is very effective technique, I must say. CE3B cyst located in segment 1, puncture, catheterization. It looks like a bunch of grapes. We irrigate in the same day and try to evacuate everything. The next day, we completely evacuated all the content, and we discharged the patients in 2 days. It was located in segment 1, which means that the part of the liver between IVC and portal vein. What are the cyst changes after percutaneous treatment? We asked this question at the end of 80s, and we carried out an experimental study by sheep to assess and compare ultrasonographic features with macroscopic and microscopic changes in order to define the healing criteria. And sheep 4, before the treatment, and 4.5 months after the treatment. In that study, we developed standard catheterization technique, the second technique. And on microscopic examination, untreated cysts were demonstrated to be thin, distended wall, bright surface, and crystal clear fluid, which is opposite to treated cysts, which were demonstrated to be amorphous cyst-like lesion with thick wall. On the microscopic examination, there was no viability feature. On microscopy, endocyst completely detached from pericyst. And there were calcification, dystrophic calcification on the pericyst. We concluded that percutaneous treatment is a safe and effective procedure, and ultrasonographic features are compatible with the features obtained on macroscopic and microscopic examinations. On the basis of this study, we defined the healing criteria, which means that reduction in size and volume of the cyst, thickening and irregularity of the wall, gradual decrease of the fluid component in the cavity, and finally solidification. Which technique and when and why? There are 3 techniques. There are several types of liver CE. For CE1 and 3A, Garby 1 and 2, we use P.A.I.R or catheterization. The question is that which one is chosen in which condition? We replied this question by a prospective randomized study to compare the results of P.A.I.R and catheterization techniques. We recommend, on the basis of this study, we recommend P.A.I.R is a first technique. However, for 10% of the patients or cysts who underwent P.A.I.R technique for the treatment, we have to use standard catheterization technique because of 2 reasons. First, if a cystobiliary communication develops after first puncture, we have to pass to standard catheterization technique from P.A.I.R technique. Or during the procedure, sometimes we have some difficulties, technical difficulties, to continue for P.A.I.R techniques. In that situation, we prefer to pass a single catheterization technique in the same session. Treatment result of CE1 and 3A, there were several small series in the literature. Until 1996, we published the first long-term results of percutaneous treatment in the liver. And the results were associated with 2% of recurrence, 10% of major complications, and almost 3 days hospital stay. And the following literature confirmed these results published in 1996. And some comparative studies, there are some comparative studies in the literature. The one published in 1997, P.A.I.R was associated with lower complication rate and shorter hospital stay when you compare the results of surgery. And the other one have similar results published in 2017. Our unpublished data also confirms similar results with lower recurrence rate. There is one of the oldest meta-analysis. P.A.I.R technique is associated with lower mortality rate, lower major complication, and lower recurrence rate, besides shorter length of hospital stay, if you compare the results of surgery. What is the situation for CE2 and CE3B? There is only one retrospective comparative study in the literature published by our group in 2017. We compared the results of P.A.I.R standard catheterization and moquette techniques for the treatment of CE2 and CE3B. And there was statistically significant difference between P.A.I.R and moquette in terms of complication. But on the other hand, there was statistically significant difference between moquette and the others in terms of recurrence. Therefore, we concluded that moquette for the treatment of CE2 and CE3B is a safe and effective procedure. But we need prospective randomized study to compare the results of moquette and surgery, in my opinion. If we talk about the overall results, during the follow-up, no sign of viability, more than 95% of the patients and cysts. The volume reduction rate after percutaneous treatment is approximately 80%. Minor complications such as fever, pain, minor hypersensitivity is easily treated. Mortality rate is very low with P.A.I.R, which is maybe almost 100 times less than surgery. There is no dissemination in the literature after percutaneous treatment. Neither dissemination nor cholangitis was encountered. Serious anaphylaxis is a real danger, a real risk. That is why we carry out the procedure under general anesthesia, and serious anaphylactic reactions is seen up to 3% of the patients. Infection is one of the major complications treated by every abscess, percutaneous drainage of abscess plus appropriate antibiotics. Bile drainage, leakage to the biliary system is seen 6 to 8% of the patients and treated accordingly. Sometimes it is also possible to treat percutaneous treatment in this patient. We just embolize the fistula between the biliary tree and the cavity remnant. And the next day, there was nothing problem in the patient. One of the major complications, recollection of the cavity seen up to 3%, and the recollection is treated by second intervention, and sclerosis is carried out by using ethanol. Hospital stay is almost 3-4 days. Yes, I'm going to finish. Recurrence rate is around 3% in the largest series, and the recurrent cyst, as seen in this case, is treated by second intervention. The aim of the surgery, one of the aim of the surgery, evacuation of the cystic cavity provided by aspiration or drainage. Inactivation of the parasites is provided by hypertonic saline or ethanol. Removal endocyst is provided by irrigation of moquette technique. Obliteration of the residual cavity by introphylexion or similar techniques is provided by sclerosis by ethanol. And we don't need to remove adventitia of the cyst. What is the take-home points? Percutaneous treatment of liver CE is an effective, safe treatment for viable cyst. It has already become a serious alternative to surgery. Here is accepted technique for CE1 and 3A. Standard catheterization technique is applied whenever indicated during your after P.A.I.R. Mocket technique is very effective for CE2 and CE3B. Percutaneous treatment is associated with lower complication rates, shorter hospital stay, and lower recurrence rates. It was experimental in 1980s, but in my opinion, there is no room for surgery now as percutaneous approach has become a routine and first choice alternative. Thank you very much for your attention.
Thank you very much, Professor Echinococcosis. It's very interesting to hear you. Is that any question in the public? One question. Just one.
Yes, congratulations. Yes, je vais parler en français, ça s'adresse à vous la question. J'ai trouvé que les hépatectomies pour kystique et idacidose étaient très hémorragiques, qui nécessitaient souvent le clampage du pédicule hépatique. Quelles sont vos précautions que vous recommandez?
La question pour Jean
Après,
Harmsen.
peut-être après.
Mais est-ce qu'il y a une question sur la technique percutanée?
Voilà, donc après.
Yes, Karima.
No, it's not just for you. It's your technique is very interesting. For that
Everybody is convinced of the efficacy.
The efficacy of your techniques, and
thank you to give us an overview of your very large and impressive experience with this approach. Thank you very much.
Thank you. Thank you.
Thank you very much. Nous allons passer maintenant à la dernière communication avec Laurence. Peut-être que tu veux répondre? Oui, voilà.
Vas-y, prépare-toi.
Le principe du clampage, on rentre toujours dans des controverses après sur le clampage. Faut-il le faire? Faut-il pas le faire? Si on peut mener une intervention sans clamper, faut la mener sans clamper. Si c'est nécessaire de le faire, aujourd'hui, il y a quand même pas mal de travaux qui montrent soit un clampage continu avec des formes compliquées, on va vite dépasser les temps limites, mais il faut faire des clampages intermittents. Si on fait la chirurgie hépatique régulièrement avec des clampages intermittents, on arrive en anticipant les temps de repos, les temps de travail. Oui, c'est une maladie inflammatoire, il y a une réaction de l'autre. Oui, ça peut saigner plus. On a fait un travail là où on avait transfusé quand même un certain nombre de malades, hein, mais ce n'est pas technique majeure. Donc voilà, c'est toujours la même chose. Le constat, je n'ai pas de l'information par rapport au truc si cette chirurgie pour la maladie échinococcose versus les autres cas, je dirais, foie non cirrhotique, bien entendu, méta, par exemple, est plus ou moins hémorragique. Je n'ai pas d'informations là-dessus, mais le fait de clamper n'est pas péjoratif, n'est pas une complication. C'est juste un outil de plus qu'on a à possession. Hein,
voilà. Donc, une dernière question. Voilà, une dernière question. Voilà.
Alors, il a été rapporté des cas d'intervention sous laparoscopie ou thoracoscopie. Est-ce qu'il y a une place dans cette pathologie pour les abords endoscopiques?
Oui, c'est-à-dire que thoracoscopique, nous avons un gros problème, c'est-à-dire que c'est pas que le parasite, c'est les lésions qui entraînent qu'il faut savoir gérer, qui peuvent être gérées en vérité qu'en opératoire, on ne peut pas les prédire à l'avance. Tout à l'heure, c'est la réponse à votre question de tout à l'heure. C'est en opératoire qu'on décide s'il y a une grosse fistule, petite fistule, les gestes à faire, pas gestes à faire. Et je pense que c'est peut-être un peu la même chose.
Est-ce que ça peut se faire par thoracoscopie?
Oui, mais nous ne préconisons pas parce que nous ne pouvons pas gérer à l'avance, nous ne pouvons pas prédire ce qu'il y a lieu de faire.
Donc,
les principes sont les mêmes. Hein.
Voilà.
Les principes sont les mêmes, c'est-à-dire qu'il faut essayer, dans la mesure du possible, de ne pas avoir des fractions sur le kyste. Pour être, donc, je crois qu'en célioscopie, que ce soit à ciel ouvert, il faut entourer les champs, enfin, il faut s'entourer de compresses avec des scolicides ou des protoscolicides, éviter le plus possible de manipuler le kyste, de passer autour du kyste. Donc, il est certain qu'en célioscopie, il y aura des zones favorables, les segments antérieurs du foie, les kystes qui sont en partie exohépatiques, mais des lésions profondes, comme on nous a montré le P.A.I.R, on va avoir des limites à ce moment-là. Mais en revanche, si on part en disant on va faire une hépatectomie réglée, on rentre dans une chirurgie classique. C'est les lésions où on va traiter le kyste et on passera au contour du kyste. Là, on va avoir des des impératifs qui doivent être respectés. Hein.
À mon avis, si j'ai bien compris tout ce que tu nous as dit, le message important qu'il faut retenir, c'est ne pas ouvrir le kyste. Alors, si tu peux faire tout ce qu'il a dit par célioscopie,
Voilà.
pas de problème. Mais après, il faut sortir le kyste sans le faire exploser dans la paroi.
Voilà, pour avoir travaillé un petit coup, c'est pas évident.